Yeah, the background of this analysis is that women with estrogen receptor positive breast cancer continue to have distant recurrences 5 years after they finish endocrine treatment. So there's a really important clinical question to accurately predict who is going to develop a distant recurrence. And therefore we took the approach in using clinical pathological parameters to develop a simple prognostic tool to predict late distant recurrences. We know that clinical pathological parameters are important not just for the first 5 years for prognosis, but some of these features or clinical features have also shown to be highly prognostic for late distant recurrences, and in particular nodal status, and to a less extent tumor size and grade. And recent data from a large meta-analysis from the Oxford overview has also shown that the risks of late distant recurrences can lie anything between 10 and 40%. And this is depending on the original tumor size, nodal status and grade. And therefore we took the approach to using this clinical information and incorporating it in a simple prognostic tool.
Do you know of any of the numbers that you could rattle off? I'm sure you've talked about it plenty of times already over the course of the conference, but success rates, accuracy, that kind of data.
In terms of this tool specifically, I mean, we have looked first, we have developed this tool first, looked at the initial clinical parameters on its own, and to see which of these clinical parameters are prognostic for late distant recurrences. And we have observed that apart from 5 years of endocrine treatment, all the clinical features are highly prognostic. So this is nodal status, tumor size, grade and age. So we incorporated these highly prognostic univariately features into a multivariate model, and have seen then that in the training data set, when we applied this prognostic tool in a training data set, that around 43% of patients are categorized as low risk of a late distant recurrence. And they only had a 5 to 10 year distant recurrence risk of less than 3%. We then validated this tool in our validation data set, the Big 198 trial, and have seen that the risk stratification using these risk groups from the training cohort, that we found very similar risk stratification and 5 to 10 year distant recurrence risks in the validation cohort. Again, roughly 40% of patients were categorized as low risk, 25% as intermediate risk, and the remaining as high risk. We then combined these two data sets to get increased risk estimates for late distant recurrence. And of the 43% who were low risk, they had a 5 to 10 year distant recurrence risk of 3%. This indicates that extended endocrine therapy is of limited value in this patient group. When we compared it to the high-risk patient categorized by the CTS5, they had a 5 to 10 year distant recurrence risk of almost 20%. And this suggests that these women are good candidates for extended endocrine therapy. For
clinicians looking to take this data forwards, is there any way that they can start incorporating that into the care and maybe increasing that number up from the 20%, because we don't want to be mistreating an extra 80% of people who wouldn't be best suited to the extended care?
Yeah, sure. We aim to make this CTS5 prognostic tool, this algorithm, available with a risk curve and readout table. So essentially, in the end, we would like to provide the clinicians with a risk calculator that they can use and simply input the clinical information which they already have, so there's no further need for testing or any additional information needed. So they can enter all this data into the risk tool, which will give them then the CTS5 value with an associated 5 to 10 year distant recurrence risk. So women are then categorized into low, intermediate or high, and therefore they can then decide with the patient whether extended endocrine therapy is a good option for the patient.
Well, it sounds like we've covered some of the past, present and future for the paper. Is there anything else you can think that we've not mentioned?
We have obviously trained this prognostic tool in a large clinical trial and validated in a large clinical trial, but it would be good to see also if we can do that further validation, specifically in premenopausal women, because at the moment this prognostic tool is only applicable to postmenopausal women. So in a premenopausal cohort, it would be very nice to see if we can achieve same risk stratification and therefore see if women could go on extended endocrine therapy if they are premenopausal.